2:03, and we're going to go ahead and get started. Again, welcome you all. My name is Gabriela. I'm with the EMI Advisors team. We are starting our 5th work group meeting. Today is June 15th, and we'll be reviewing and discussing our use case 1 and 2. To give you a warm welcome, you are joining the Social Determinants of Health, Public Health Use Case Work Group for Chronic Disease Prevention. Due to the large number of attendees, everyone has been muted upon entry to prevent background noise. We would love for this calls to be as interactive as we can. You are encouraged to use and provide feedback via the chat. As you can see here, please send all chat messages to everyone so we are able to see them and triage them as they come in. We also encourage you, if you would like to speak, unmute yourself. We can have you, if you don't mind using the reaction featured, raise your hand virtually. That will be a good way for us to find you and our participants and spotlight you and let you give your input live. And this session is being recorded. We are posting meeting materials, including the recording, within 2 business days via our Confluence site, and you'll receive an email notification when things go up. I see some new members have joined us and they're saying, well, hello in the chat. Please continue. We love to see that. For today's agenda, we'll start with a bit of grounding, going over our standing items, and then diving into a recap of the feedback received on use case 1 components, and then review and discuss use case 2 personas, a story, and relevant components, and we'll wrap up the call with next steps and homework. If you not have done so already, we cordially invite you to join the work group officially via our Confluence site. We'll put that link in the chat for everyone's awareness. If you are on this call, you have the information. If you are wondering how to officially join, you do have the core team here that supports all communications related to the work group, myself, Gabriela, Savannah, and Kyla at CDC. So we encourage you to reach out with any questions. For those who might be new, we recommend you to whitelist our work group listserv, which as you can see here is highlighted, listserv at HL7. You can add your contacts or contact your IT department. This will support not going the messages to spam, so you can just get them in your inbox. And we'll go ahead and put the link in the chat. Thank you. So we have come a long way. 4 sessions have been completed. We started back in April, and now we are on June 15th. So today, as reviewed earlier, we have our set agenda for the day. And just a reminder of the sessions left. We have 3 sessions left after today. The objectives for today really center around reviewing the feedback, the input received from workgroup members on use case 1. And you will see an overview of those changes, and then really obtain your live feedback on use case 2 personas, stories, and components. As a general reminder, as you know, this is, we want to clarify what is out of scope under this project. So we are now defining data exchange standards or data elements. We're also not supporting activities that are not directly listed on our workgroup project charter. And we'll put the link of our workgroup project charter in the chat for everyone's reference. It's really our our work group commitment, what are we aiming in the timeline to cover. So all the information for new members, we recommend for them to get familiar with the work group charter. We're now providing incentives for implementation of the use of the use cases developed. And we're now developing a FIRE implementation guide. We are working closely with other FIRE accelerator programs, such as the Gravity Project, but we're not developing one. So we just wanted to clarify that. And for some of you may be very familiar or may not be familiar with the Gravity Project. Our background and our foundation for this work, it's really centered on the Gravity Project use cases. The Gravity use cases focus on the functionality and interoperability required to allow an end user to document, retrieve, send, exchange, and aggregate coded social risk data. For example, food insecurity. The use cases that you see here listed 1 through 3 are high-level descriptions of the most value-add interactions. So the first one being documenting social determinants of health data in conjunction with the patient. So, and they're all are centered within the primary care setting. So that may happen in a doctor's office or a community health worker doing that screening in conjunction with the patient. Then, the second use case here listed is documenting and tracking social determinants of health related interventions to completion, which is that bi-directional referral. And then number 3, gathering and aggregating social determinants of health data for uses beyond the point of care. So we wanted to highlight that our work group and our deliverables within this project specifically are focused on this last use case, aggregating data for uses beyond the clinical care perspective, and really we're reusing it for focuses on the upstream factors to support public health. We will put in their chat for some of you that may be visual. We really kind of here acknowledge the coded terminology that has been developed and used through the Gravity Project, through those 4 core activities, which includes a screening, diagnosis, goal setting, and intervention. And just highlighting here that currently there's no use case that exists to define the upstream use of SDOH data for public health. And that is where we come in, right? So this work is really building off Gravity Project, and our focus and work with CDC is to move and look at the use of data from the public health perspective and really figure out what this high priority use cases can support. For some of you, again, who might be visual learners, to give you a hindsight or like a high level overview, in the past, the Gravity Project has set the foundation by making significant strides in establishing the representation of social determinants of health data across and between health and community-based systems. And we have developed over 17 domains to do that work. Presently, we are, of course, focusing on the clinical encounter exchange with non-clinical and administrative systems. The Gravity Project is leading an implementation guide as a FIRE accelerator project, as well as new work with pilot sites who are testing this coded terminology as we speak in real world and test environment setting. So that is the present. And through this work, the future state that we're looking at, we are, as a collective group, we are designing and will publish up to 3 high priority use cases for public health. And this really, just, to reiterate, go beyond those developed by the Gravity Project. So to put things all a little bit in perspective, for some of those returning members, you may recall this image, which is a social determinants of health ecosystem. So when we think about upstream, right, it's that community impact, but everything starts at the individual level. So as we move toward data interoperability across acute, primary care, and public health, we have a significant opportunity to better arm the SDOH ecosystem with more timely, more granular, and more measured data to leverage from electronic health systems. There are many gaps, we understand that, so this really is kind of the midway point of figuring out those gaps, but then also emphasizing the use of the narratives for public health to improve individuals and population health. I would like to share and invite you all to read a success story published by the Gravity Project recently. The blog is entitled Transforming Assessments and Referrals for New Jersey Residents. I'll drop that link in the chat, and that is an example of a success story of how the Gravity Project terminology and use cases can be applicable in real world settings. I'll invite you all to read that, and I'll pause here and see if there are any immediate questions before we move on into the rest of our agenda. All right, hearing none, I'll pass on the mic to our colleague, Amy.
Good afternoon, everyone. Welcome to this meeting. So what I'm going to do is first recap a little bit about the personas and the story that we're basing the use cases on, and then talk about the feedback we got, do a quick recap on use case 1, and then talk about the feedback we received. So next slide, please. So just as a sort of quick overview, and I noticed we have a number of new members. We have some folks from state agencies and from FQHCs. So, you know, again, this recap is just to sort of ground us all again on what we're talking about. But, you know, personas in use case development are really fictional characters to try to really make the story that we're using for the use case development very real and relatable to all of, you know, to you in different roles. So our personas are Kevin, who's a care coordinator at a FQHC. We added Jessica last time at your suggestion, who works at a community-based organization. We have Claudia, who's a public health analyst at a county health department. We have Victor, who's at the state health department, and we have Michaela, who's a project officer at CDC. And for those of you that have been on the call, you know, you may recall that we have one large story with 3 parts or 3 chapters, and those each equate to a use case. So the first part of the story that we had talked about was that both Kevin and Jessica were attending public health advisory committee meeting for the county health department, and happened to mention that they noticed that there was an increase in their clients and patients with food insecurity. Claudia was doing a community health needs assessment at the county health department and wanted to leverage some SDOH screening data to from clinical and community providers, really to learn about more about the food insecurity, and particularly for individuals that were in areas where there was prevalence of high diabetes. And she learns that there's a regional HIE that's exchanging data and establishes a data use agreement with them, and then collects data from both the through the HIE from the community health centers and community-based organizations. The second part of the story really now brings into the state for those that are here from state agencies. And Victor at the State Health Department is preparing a continuation application for a cooperative agreement with CDC through their Diabetes Translation Division. And he wants to also really focus on decreasing food insecurity in areas where there's high prevalence of diabetes. And he learns of the regional HIE, as well as, but that's just for one region of the state. There's other clinical and community-based providers that have data that may be screening and identifying SDOH needs. And he also learns that at Medicaid that they may be collecting some of this through Z codes. And so he really works to try to get this data together, to look at it, and also to try to overlay it with information on where there may be diabetes prevention programs and other lifestyle change management programs for individuals with diabetes. And then the third part of the story, really, which will be use case 3, and we will discuss in the next meeting, is Michaela, who's a project officer at CDC, was speaking with Victor at the state, and she learned how he leveraged using clinical and community and Medicaid data to better understand these issues that he was looking at around food insecurity in areas where there's high prevalence of diabetes. And Michaela wants to really encourage the awardees of CDC funding to monitor their programs and encourage grantees to really track and report some of this information about individuals with diabetes in areas where there's food insecurity. So that's just a bit of a recap of the story. Next slide. And here are our personas and their roles. Next slide. And so the use case one components, as you can see here, we talked about this last time. We have the human actors, which are the personas, they're business actors, the agencies where they work, the system actor, the systems that they're interfacing with, where their data is kept, and then what the technical role is. Next slide. And here's the transaction diagram. We're not going to go back through all the assumptions that we used for use case one and preconditions, but we had all of that, and it's in the document that's on the Confluence site. But the transaction diagram here really is again showing that the FQHC, the Federally Qualified Health Center, and a community-based organization are sending SDOH encounter data in a standard format to the regional HIE, which also has clinical information, and then the HIE is sending it to the county so that the county can use it in its community health needs assessment. Next slide, please. So we had two individuals comment, and I'm going to go through sort of the themes of the comments and how, how we've incorporated them or how we plan to have further conversation about them. So one comment related to the fact that a community health needs assessment, this type of a community health needs assessment, may really have inherent biases based on gaps in data collection. And that this could, based on where the data is coming from the FQHC or the CBO, if it's not the whole county or whatever the case may be, certain groups may be excluded and it may impact the actual outcome and analysis. And so to address this concern, we added an assumption in the assumptions section that basically said that the county health department will assess where the data is coming from, and then adjust accordingly for data collection bias. So if there's certain areas that are missing, that would be, they would provide the context and do that assessment. The next themed area of feedback was really, and this we spent a fair bit of time talking about at the last meeting, was around sharing identifiable versus de-identified data. And the comment that came back to us was, unless there's really a treatment purpose, the SDOH data that would be shared for a community health needs assessment really would likely be de-identified. So why aren't we just constraining this use case to de-identify aggregated data? And while we fully support the concept that for a community health needs assessment, it is likely that the data would be aggregated and de-identified, we really chose, and I think we talked about this last time, to avoid being specific about whether it's identifiable or de-identified to allow to really support the broadest applicability. We did include that the data would be encrypted data so that there would be some security protections. And we also had in the assumptions that all local, state, federal privacy, security, and consent laws and regulations would be adhered to. So if the SDOH data really can't be shared for purposes, it's not for treatment, or even the clinical data not for treatment, then it would need to be aggregated and de-identified and aggregated. Next slide, please. The next comment was, again, trying to suggest that we be more specific about what medical and SDOH data are actually being shared as part of this use case, particularly around what diagnosis and things like that. And so we've added an assumption that the medical diagnosis that would be shared would be related to diabetes, and as well as SDOH risk data would be shared. And we anticipate that, the very specific data elements would later be identified through the future development of an implementation guide. So that's how we were planning to address that comment. And the last comment was really suggesting that we specify more about the county health department's data repository. We've made an assumption, and we state in the assumptions or preconditions that the county health department can accept standardized SDOH data from a trusted intermediary, such as an HIE. And so the question is sort of, what are the requirements needed at the county health department's data repository to be able to accept this data? And how would the data be used? So we've already articulated that in this use case, the data at the county is being used for community health needs assessment. We are going to come back in just a minute and have a little bit more discussion and seek your feedback and thoughts and discuss this particular topic around requirements for the county health department data repository a bit more. So next slide. Also, at the last meeting, we talked about, we had gotten a lot of feedback initially around adding more personas to the story. And we had discussed that due to resource and time limitations, we really couldn't have more than 5 personas. But we encouraged all of you to contribute to personas. And there's a place on the Confluence website where you can do that. And we did receive 4 additional personas. A FQHC clinic staff, an FQHC director, a patient, and also a business owner of durable medical equipment. The full personas with their goals and their challenges are on the link that is in the PowerPoint here. So you'll be able to go and see that. And again, the point here was, and we urge you to continue to add personas because we will include them in the whole use case package, and they may be used for further work and further development if additional use cases are going to be built out after the 3 that we are working on through this particular work group and project. So next slide. So the questions that we wanted to come back to you on and get a little bit more discussion, we have 2 of them. One is what I had just alluded to, which is, what is the specificity that we need to include that's missing from this use case around the requirements for the county health department data repository to be able to accept standardized SDOH data. So I'm going to stop there and see if any of you have any thoughts, suggestions, comments, and see if there's, I don't think there's any comments in chat yet on this. Also, revised use case 1 document is being posted, so you can see the 2 assumptions that we added that I referred to earlier. Any thoughts on whether we need more specificity in this use case around the data repository requirements to be able to accept the data coming from a trusted intermediary or accept the SDOH standardized data? Ray, did you want to say something?
Yeah, I was in thought. So I was thinking, so I think you might have just answered it when you were, so this assumes that somebody else, an HIE, a distributed data network, is already aggregating the clinical and community data. And therefore, what does the health department need? So the health department, you're not asking, does the health department need to perform that role and what type of infrastructure would they need to do that? It's what, just to clarify to ask. So someone else's, some other entity is that the health department is a part of has already done that. Is that correct?
Yes, for this first part, I'm going to answer that in 2 ways. For the first part, the story says that the county health department is getting the data from the HIE, that most of the providers in this county are already participating in the HIE and sending information, and some CBOs and some clinical providers are sending SDOH data. The use case 2 that we're going to talk about when we're done sort of having a little bit more discussion here on the use case 1 gets into the state. And when we get there, Sheetha will be walking through all of that with the group. And there you'll see that, there are multiple different data sources, an HIE, but that's only one region, clinical and other community providers, Medicaid, that are all sending to the state. So, right now the question was really, the comment we received was, don't you need to be more specific about what the county health department needs, their specifications, or the specificity of what they need to be able to accept the information?
Okay, so yeah, I'm on it. I don't have any comments. I'm not sure what, I would have to know more what they mean by what, or maybe you can explain what is meant by specificity in terms of, like, is that to receive, like, to receive that HIE data?
Yeah, so let me try this a different way. For anyone who's on the call, who's either at a county or a state health department, do you have, like, let's just say diabetes registries or other registries where you may collect chronic disease registries where you may collect diagnosis information? And then if you were to incorporate SDOH risks and needs, would you be able to add that in? So I'm that's just one, I'm just trying to stimulate thinking about what kind of specificity, if you're taking in aggregated de-identified data, or if you're taking an individualized data and you have justification, would you, what would you, when the data comes to the health department, the county health department, where would it go? How would you take it in? How would you then analyze it? All right, so I'm looking in chat here while you're all thinking about that. So we have one comment about, is there a specification for the use of standard census geography? I actually don't have an answer to that. And some states have said that they have cancer registries, but they're not sure if they would be able to take in the SDOH data. And I see Julia has her hand up, so we'll flip to Julia.
Sure. So, we work with ASTO a lot at NAC. So what ASTO has said a number of times is that there's a lot of variability, right, in different state and county health data requirements and capacities. So, this is an example where we might even want to have like 2 or 3 examples where the infrastructure is significantly different. If we really wanted to, describe what the experience is like at different places around the country. If we want to standardize to a specific version of that, I think it's more than reasonable. I don't think we have to, create 3 flavors. But in general, there's not a ability of public health agencies to quickly flex, because usually they have some sort of hosted infrastructure that they can't modify on their own. So I would validate what somebody's comment was about, it's not possible necessarily to change the requirements of a relatively structured activity like public health reporting. There are cancer registries also, obviously, at the national level, supported by ACS and ASCO and others. So it might be possible to use some of those requirements and repurpose them.
Great.
But I think if you have one here right now, you kind of have one, but we could sort of say, we'll pick a moderately innovative and flexible county health department as a test case or example and use that. But I think we would want to call out the fact that that maybe not be representative of what different organizations experience locally.
Great. Thank you, Julia. And Ray, we'll come back to you in one second. I think your comments are obviously, thank you for contributing those, and very much on point. In the transaction diagrams, we have alternate data flows. This was a little bit different. And so I want to get to Ray because I believe he had his hand up. Oh, he just said no need to come back to him. Okay, he likes your idea. The real question is, does this use case need that specificity of a couple of different models, or is it okay to be sort of silent and absent on it? For the data flows, we have alternate data flows, recognizing, again, that there's a lot of variability in how data can flow, both to county and state and at the federal level, and even if data needs to flow back. So I would also just put out the question, do you think the use case needs more specificity? And then, again, if there is more specificity, there may be several different models. Any thoughts on that?
A comment from Julia in the chat saying I wouldn't be silent on it. A useful IG or document should have that guidance.
Okay, so thank you, Julia, on that. And whether that goes more into an implementation guide versus here, I think is also what we're working towards. And I see that Mariella is talking about a COVID registry. And do you want to add anything there on your comment about the COVID registry and filling information in on that? Mariella? No? Okay, and I see Julia. Do you want to add anything else and elaborate on what you've put into chat?
I'm definitely not an expert in the geocoding question, but we have worked with the team at Harvard who are, and they actually use, I think, a smaller geocoding, what should I say, area than the census tracts. They do, I think, city blocks or something like that, but we could get that information and try to apply it here. I don't think that, the ability of a clinical organization to like flex and be like, oh, show me my geocode is not necessarily broadly available. But in terms of best practices, it would be good to push people in those directions.
Okay, great. All right. So thank you. We're going to move on to the next question. And that is, we also had a comment come back around sort of, in this use case, we have HIEs, we were using the HIE as the data trusted intermediary to send information to the county health department. And the question really is, do the HIEs have the data that a public health jurisdiction could leverage really to support determining prevalence rates of chronic disease? And again, that may be very variable based on the HIE, but in general, we just wanted to throw out the question and see what the group's thinking was about, does there tend to be sufficient or the right data to be able to determine prevalence rate of chronic diseases? And I can see we have a couple of comments again about variability from state to state in terms of what can be leveraged. Any additional thoughts on that?
This is Angie. Can you hear me?
Yeah.
Can you give me, sorry, I don't have a clinical background. So what specific clinical data point leads to prevalence? Like what if I think about it as an HIE and the content that I'm pulling out of an EHR, what am I looking for specifically?
I am not the epidemiologist. Go ahead, Sheila.
Carrie, go ahead, please. Love for you to answer that.
Sure. So yeah, somebody had mentioned about it's difficult to estimate the sampling population. So for example, in Washington State, not everybody is required to report to an HIE. So you're not seeing the entire population that you can sample from. There's no statistical validity to what goes into the HIE, so it makes it difficult to estimate prevalence for any given population.
Okay.
I hope that is helpful.
So nothing from a clinical data content. Prevalence really is just being focused around, how many times can we say we have encountered such and such chronic disease across our entire master patient index, whether we have direct connectivity to providers or we have connection to some public health state registry. Similar to syndromic, right? Okay.
Yeah.
So I think you're already seeing it. So, but it's all over the board on the connectivity that HIEs have with public health and what rights to data or data governance may or may not be in place, or what restrictions might be in place. I think the question's not, do we have access that we can leverage? It's more, how do we ensure we have access so that we can leverage this? And what, from a policy perspective, getting the data and getting it to you is the technology is not the problem. This is a governance issue. This is a incentive issue. So I would respectfully propose that maybe the better question to address is, where are there opportunities for us to ensure or encourage or mandate / require, if I might be so provocative, to make sure that we can do that in this way.
Okay, thank you. That's helpful. All right.
This is Ray. If I can just add one more question,
Sure.
comment. In doing some of our work in the chronic center with the HR data, I mean, we've had pushback, and this might just be within our center, and so I don't want to speak for the entire group, but when using the term prevalence, and so sometimes we can do rate of something in a specific population, but a lot of this clinical data, as well as the social determinant of health data, and social service, I mean, you have presence of someone, and what they show up with in terms of like they're diagnosed with diabetes, but you don't have the absence data, so the denominator becomes very hard to define. And so I defer to the OIIRM team as like if that's going to be tricky, is since you're developing this for them and everyone on the call, but how we use prevalence in the chronic disease center, and what you're suggesting we can define from these data. Because it's not going to give you a population prevalence, and we don't always have a denominator.
Okay. Helpful. Any other thoughts? We'll take all this back and work with the information you've shared with us. And just to keep us on track, I'm going to move us along now to use case 2, and Shito will walk everyone through that. But thank you very much.
Yeah, thank you all for the great feedback. And before we move on, Amy, there was one question that came in the chat from Suzanne. Can you clarify that the SDOH access from counties being discussed is not self-reported or volunteer data?
Thank you for pointing that out. I had missed that. The assumptions that we've made in use case 1 is that clinical and community-based organizations are screening for SDOH risk. And so when you're asking if it's self-reported, it's reported in the context of a screening through a clinical or community-based organization. So I don't know if that helps answer the question. And Shito, if you want to add to that, go ahead.
I'll just add to that. I think in the Gravity project, in the use cases, Suzanne, they do have examples of like an individual at the health center who's self-reporting that data through a tablet. So they walk through those different flows of how data could be captured in a clinical context, which could be self-reported, if that's what you mean when you talk about self-reported or volunteer data.
And I can see that Carrie says here that at their health center, it is self-reported when they're screening.
Yep, exactly. Yeah.
And there is self-report. I mean, yes, we also have some comments here about self-reporting and some of the challenges with that. I clearly recognize, that individuals don't have to acknowledge or identify if there's a risk or need if they choose not to. So.
Great. All right. Well, thank you, everyone. Very helpful discussion. And yeah, we'll incorporate this feedback. Oh, and I'm just going to pause. I see Dr. Lucas has a comment. Working with the HIE, these providers are mandated to connect, which does provide prevalence rates within that HIE, but still have gaps at the state level. We often have to supplement claims data to have additional insight into diagnosis and encounters. Awesome. Well, Dr. Lucas, I'll definitely ask for more of your feedback as we get into our second use case, because we talk about combining data now from different sources. So super appreciate everyone's chats, and feel free, we'll be monitoring chat as we go. And then if folks would like to, unmute themselves and raise your hand, yeah, feel free. We love when folks just interrupt and ask questions or provide comments. So we'll go to use case 2 on the next slide. And before we jump into more of the details surrounding this part, we just want to have folks in the back of their minds to be having these questions around, again, is this meeting the needs of public health professionals? For folks that might be joining us for the first time, and welcome, we're so happy to have you. We wanted to ensure that our use cases, touched all levels of public health, as well as having, ensuring broad applicability throughout the ecosystem. And even though for this, complex story, we focused on food insecurity as the social risk or need, and then diabetes as the chronic disease. We hope that these use cases could be applicable for different social risks and chronic diseases. And so, as we go through this in more detail, please be thinking about these questions that are on the screen and ensuring that this is really providing a compelling reason to leverage the data to support public health. And is it helping us drive towards, a desired future state? And so if we go to the next slide, just to give folks now a little bit more detail. So Amy gave us some nice high level aspects to ground us in the story. And then Amy, I'll ask you too, as you're monitoring chat, feel free to interrupt me if anything comes up, because I know we got some nice comments in there. So for this kind of part 2 of the story that, we want to discuss right now, we have Victor, who is our public health program director at the state level. And a few meetings ago, when we talked about the personas, we said, Victor, he loves building partnerships with stakeholders across the ecosystem, learning about innovative solutions to challenging problems. And he doesn't want to let perfect be the enemy of the good. And some of the challenges he's currently facing is that, his department is short-staffed. The leadership has been, really focused on the pandemic response, and that he's challenged in that the data he has access to is limited in helping him identify what community resources are available to help address his population's growing social needs. And part of his goals, just from a professional day-to-day perspective, is that he wants to be able to help advance and deploy those needed interventions, social services, and programs and resources to address social risks and needs, as well as address health disparities, especially for those at risk for or managing diabetes. And so with this story, Victor is conducting an assessment on the different diabetes programs across the state. And again, as Amy mentioned, he wants the results of what he's learning to be included in the state's continuation application for their cooperative agreement, supported with CDC's Division of Diabetes Translation, or DDT is the acronym that we might use. So if you hear that, and given the COVID-19 pandemic and its economic ramifications, he wants to focus on decreasing food insecurity in the areas of the state where diabetes prevalence is highest. And he also wants to determine if there are those, CDC recognized programs that in those areas where that's occurring. And so he learns about the regional HIE that can provide limited but timely data on diabetes and food insecurity. And maybe we won't use the term prevalence. Well, we can change that potentially. And food insecurity by zip code for certain geographic regions within the state. And then that data, along with data from other clinical and community providers who may be operating in other geographic regions of the state, supplemented with existing Medicaid claims data and specifically Z codes. He wants to combine that data and then hopefully overlay this aggregated data with the state's DDT funded program data by zip code to have more awareness about what's happening across the state. And we also say in the story, and we don't say this, I don't think we have it on the slide, but, we do want to just recognize that Victor is aware that this does not give him complete data on all persons in the state, but it gives him access to standardized, interoperable, and timely SDOH related data that he can leverage to help monitor diabetes prevalence and food insecurity. If we go to the next slide, please. And so, yeah, just a quick recap again for those who might be new or can benefit from a quick refresher. The use case package is the output of this work group. It's the deliverable that we will be putting together and hopefully getting consensus on at the end of the meeting series. And so highlighted on red on this slide is the areas that we'll discuss on the call today, specifically related to use case 2. And so in our last meeting, we talked about use case 1, if folks recall, and then in our future meeting, we'll talk more about use case 3. But for today, we'll focus on these components related to use case 2. And if we go on the next slide, And again, I'll try to keep these quick, but just for folks who might be new, a little bit about kind of the key definitions in our processes that, we'll want to go through with each of, this work group through each of these areas, ensure that it's clear. And so, you have some of the definitions on the slide here. So hopefully some of these are straightforward, but, with actors, you've seen kind of the table in use case 1. We have, each actor has a role and performs a certain set of activities to support the story. And so in a minute, we'll go through for use case 2, the human actors, the business actors, the system actors. We'll talk more about the assumptions of, that we've made in the context of this part of the story, and would love to hear more based on what's coming up as you read through that and reflect through that. And, assumptions could relate to anything, to policy or process or anything that we collectively want to state up front. And if we go to the next slide, the preconditions are slightly different in that they describe what must be in place from a systems perspective in order to enable the interoperable data sharing transactions, specify the data exchange across the systems. And the message content in this context will describe the data types or categories of data that we anticipate to be exchanged. And then the post conditions describe the state of the system as a result of what is exchanged. And lastly, Amy, I think also alluded to this earlier, and we talked about this, because there's such variability, across the country, across different geographic regions, we do have a section on alternate flows that describes those other types of scenarios that could result in the user completing the goal, but acknowledge that there could be different information sources or different trusted intermediaries for this data exchange. And so we'll definitely love to hear your feedback on how to capture that and synthesize that in a way that, for anybody kind of picking up this, use case package where it's, it's clear and digestible for folks. And so if with that, I will pause see here. Amy, was there any questions that we want to address before moving into use case 2? And you're on mute if you're.
I don't see any. We do have a comment from Jennifer related to the concern about self-reported data. She mentions, I think the assumptions about the community health needs assessment need to go a step further and include something about a distinction between a stated lack of need and missing value at the patient level, even when other social determinants of health data have been provided for that patient. So
Great.
I think, kind of missing data there.
Yeah, thanks, Jennifer. That's great. I think we can take that back and step feedback and see how to incorporate that into our assumptions for sure.
Yeah, and I think, Sheethal, there was a comment beforehand just again about whether HIE, another Carrie was noting that not all HIEs are required to do reporting, and there may be waivers. So again, there was a lot of discussion about, back to the question about, HIEs and the capabilities and data that they can provide.
Yeah, that's awesome. That's great. Yeah, I think we can adjust to that wording into the assumptions as well. Great. Okay. Well, let's switch gears and go to the Word document, and I will just pull that up in a second. And again, for folks who are new for the first time, welcome. And then I did want to mention, as we were, developing, these use cases and these actors, we did try to leverage the great work that's, been done through other initiatives like MedMorph. The CDC has done some really great work in already helping define some of these definitions. And so we wanted to leverage that work as much as we could. And if folks who I know are part of many other great initiatives going on in the ecosystem, feel free to let us know too if there's other ways we can leverage, the work that you're doing in other collaboratives or standards development initiatives. And so on this table, we have now in the context of use case 2 with Victor, who is our public health program director at the state level. We have the different human actors, their business actors, the system actors, and then the technical roles they play. So a lot of this might be similar to use case 1, but now that we've introduced, Victor at the state level, that's I think the most significant addition to this table here. And then I'm going to just walk through the assumptions. And so feel free to at any point, like chat in any questions or, unmute yourself or raise your hand and Amy will interrupt me, but I'll quickly walk through the assumptions. And again, building off of use case 1, we wanted to put in, again, some assumptions that we're going to state up front. So, first is that as we go into this, we are saying that we think all the screening tools and questions, responses, and interventions have been mapped to codes developed through the Gravity project. And I will state that we are hoping to drive towards a desired future state. We know this doesn't, happen ubiquitously across all, regions or public health jurisdictions. But for the purpose of this use case and hoping to drive towards a desired future state, we do want to state that up front. We also wanted to ensure we stated again that, all of this information is, shared and accessed in compliance with those appropriate federal, state, and local privacy, security, and consent laws and regulations. All the entities have signed the appropriate governments and data use agreements to be able to enable the sharing of data, whether identified or de-identified. The regional HIE, it contains standardized SDOH data that came from the clinical and community providers in that region. And now for this use case with the state health department, which is acting as the information recipient, that they also have the appropriate agreements with all of their data sharing partners to allow them to receive this encrypted aggregated data. And again, we'll circle back on the right usage of the words, from the epidemiology perspective. And then the information recipient, again, is able to process and use this encrypted aggregated SDOH data. So we do want to make that assumption that they can then process and act on it. And then we also have introduced here the state Medicaid program. So we mentioned that the state Medicaid agency in the story that goes into a little bit more detail does have these, either Medicaid or all payer value-based care initiatives that are encouraging providers to document social risks and social needs via Z codes. So we did want to, assume that. So hopefully there's maybe more of a higher, there's more of those codes in the Medicaid program data to reflect their patients' or member needs. And then also with this, Medicaid has that MOU to share this data in accordance with their state policies and data sharing agreements with the state health department. And then just to kind of almost wrap us up here, we then say that the data being provided to the state health department as from the clinical and community-based settings, as well as Medicaid, does not provide complete data on all persons on a specified area on a regular basis. So I think that theme of that, we know that this data is not reflective of all persons in a geographic region. I think you can see that through portions of these different use case packages, but knowing that it's important, since that's a lot of the feedback that the work group is giving us, that we do want to make sure that's clearly stated in different parts of the use case package and the story. And then as I move on, so we have now the preconditions, which is more from a systems perspective, what needs to be in place here. So, from the regional HIE perspective, that they can accept that the regional HIE, can accept both and send standardized medical information as well as SDOH data. We also say that the clinical and community providers' IT systems can support that functionality as well, and that the state Medicaid agency's data repository can send Z codes to the information recipient's data repository, which is the state health department. And then here we also have, just going down further in the document, it's the state health department's data repository has the capability to do this as well. And from those external sources that are relevant in the context of this story, which is the trusted intermediary, and then directly from the clinical and community-based providers, as well as Medicaid. So we're introducing, not just now direct providers, whether they're clinical or community-based, it's directly from an HIE and as well as Medicaid. And then we also this was feedback from the work group as well. We also just wanted to assume that the state health department also had those analytic tools that can support, that can overlay this data and support it, whether it's through, GIS or mapping tools, but basically to be able to give Victor that view of what's happening in his state across different regions. And then we have the transaction, which is similar to the first use case, but sending aggregated SDOH data in a standard format. We have as well the message content, which doesn't go into the line by line data element level, but gives those data categories that we think are certainly relevant in the context of this story, which is related to screening questions and responses, interventions and diagnoses. And then the post condition is the information recipients able to accept, analyze, and act on the encrypted data. And then here's where we have the alternate flows. And so certainly welcome folks' feedback on, any or all of this, but, we know that there's such variability, across states and jurisdictions. And so we did want to just, again, state that there's different data assets that could be capturing and aggregating information related to social risks and needs and interventions. And so it's important to consider what those flows may be. And then we've said this could include, but is not limited to, knowing that this, landscape is rapidly evolving, and this could very much change, but that it could include, a compilation of healthcare payers, community information exchanges or CIEs, community-based resource platform technology vendors, other care coordination platform vendors, and just other providers' IT systems. And so some of these system actors could be the information sources as well as the intermediaries. And then lastly, on our last call, there was some discussion from folks around the usage of privacy preserving record linkage, PPRL. And so we thought that since this has come up from the work group, we did want to also, put this in this section as, something that may be considered, which is, a means of connecting records using secure pseudonymization processes in a data set, and that refer to the same individual across different data sources while maintaining the individual's privacy. Because as Amy mentioned previously, we did say we wanted to be to ensure broad applicability and flexibility in the use case package, not really, being super concrete about whether it's de-identified or identified. But then this came up as another method to consider to add to the use case package. So we did add this based on the work group feedback. So I will stop talking now and see if there are any questions, reactions, or thoughts. Yeah, would love to hear from the work group members.
Feel free to put stuff in chat as well. And it's really important. It's most helpful to get feedback and comments during this call. We certainly have time here, and this will be posted so you can look at it again and provide comment afterwards. But the benefit of the discussion now, if you have any thoughts, I know there's a couple of folks here, I think, that were from a state agency, Health and Human Services in Michigan. Like anyone from a state agency, again, does this resonate? Does this not resonate? It may be a little bit towards a future state more than what's broadly happening now, but we would really welcome thoughts, comments, suggestions, corrections, whatever.
Yes. And sorry, I did scroll all the way down. I just wanted to have folks to have the view of the actual diagram too. And then Gabby, while we're waiting and seeing them, and maybe folks are thinking or processing, maybe we can put up the slide with the questions.
Absolutely. Yep.
And if folks want, we can always scroll back to the draft document as well. But, just curious to hear folks' initial thoughts or reflections. If you are Victor, if you're someone that's worked with a public health department or supported public health efforts, is this a compelling reason to leverage the data? Is it relatable? Does it help us strive towards a desired future state? Would definitely be curious to hear folks' thoughts. Yes, please go ahead. Susie from IHS.
Hi there.
Hey.
Thanks. We've been having, I also have Captain Janet Town and Miss Wendy Wisdom on the call from IHS.
Yay.
So we've been kind of chatting while we're listening to some of the use cases and some of the discussion that we're having with Health Information Exchange. We're going through an HIT modernization, but you're mentioning a lot about Z codes and with the Z codes, the challenges, you know, we are a hospital, we have 24 hospitals, we're federal. So the first challenge is we also have our tribal and our urban programs. So when you talk about a population, they would have to opt in to participate, and they would have, the tribal programs would have to send you the information. So you might not have a full patient population of American Indian and Alaska Natives. That's the first thing that that we thought of. From an HIE perspective, we are working on that. But when we talk about Z codes, we also we look at the SNOMED codes also and the ICD-10 codes, and certain codes with like ICD-10, you know, those with the pick list for the Z codes, it's kind of a challenge because those codes map to our system, and I want to say they map to SNOMED codes, but I don't have it in front of me. And Wendy probably can talk about that. But when you're talking about the Health Information Exchange, we have a CCDA, and that's how we send the information. And the CCDA could provide some of the social determinant of health things that you've mentioned.
Great.
Wendy or Jana, is there anything you wanted to add to that?
Hi, this is Wendy. Yeah, just to clarify that our providers enters on our problem list, they enter SNOMED codes, and those get mapped. Not all of them, but some do map to ICD-10 Z codes, but not all of them. But in developing, because of certification and the requirements from USDI, we had to put in codes for assessment, for goals and treatment. And we've pretty much, you know, you basically had CPT codes. There were, you know, there were ICD-10 codes, there were SNOMED codes. And so we decided to use SNOMED codes for all of them. So if we were sending data through our CCDA, which we have already tested, we can enter and we can pass it to our CCDA for HIE exchange. It's coming in SNOMED codes.
Awesome. Thanks for sharing.
Hi, and this is Captain Town, and I'm going to jump up a level. I am not a EHR IT person. I'm a nurse by training, but at a level of thinking about the use cases, trying to capture populations that you're looking at. Susie mentioned that there would be some challenge with some of our urban and tribal populations, of course. So thinking about this particular use case and Victor, right, as a state level individual, I know from having worked with the state of Arizona, they're already struggling and grappling with how do we get tribal data. That came up long before COVID, and I think COVID has probably assisted with some of that data sharing, but it's still a challenge because the individual tribes have to make a decision, right? The facility or the tribes have to make a decision about whether or not they're willing to share that data. And so thinking about this more broadly, how do we, you know, how would Victor be the one trying to do that kind of outreach to get that data, and how do they reach out to their tribes? You know, I know here in Arizona, we had a liaison, but could that be done at a broader level, perhaps, you know, maybe with some engagement with organizations like the National Indian Health Board, who has a broader reach of tribes that are providing healthcare. So I'm still trying to wrap my head around it. It's the
No,
first
thank
call,
you. Yeah. Thanks so much for that question. And, you know, I think when we kind of embarked on this project with our CDC partners, you know, we were hearing about some of the challenges that public health jurisdictions and departments were having alongside with their, you know, the partners in the community that might be collecting, you know, all sorts of data. And so, Gabby, if we just go back to the story. So we were trying to think of when we were putting together this work group story, what are the different levers? And I'll use that word loosely that you know, that public health folks might have in absence of state policy that might vary state to state, or like you mentioned, with tribal nations, and then even with counties, and my very limited understanding, and there's obviously experts on the phone that can talk more to this, but there's a lot of variability in policy to help enable this data sharing. So when we put the story together, we thought, okay, there might be a lever, right, with the state health department in terms of having a program that is being funded through the state and CDC. So really thought about leveraging that program lever. But I think Captain Town, you mentioned something really interesting, is like, how is he going about and doing all of that engagement and having all of that? Because even though you might be responsible for a program, I think, I don't know. So for folks who actually wear those hats and have worked on this, would be really curious to know any of your reactions or reflections to what Captain Town said, or any of the folks from IHS, in terms of having to actually implement something like this.
Sheethal, I want folks to contemplate your question and come back to that, but I do want to point out that Heidi put a note in the chat, and she was commenting that, and I'd like you, Heidi, if you're willing to clarify this, I want to make sure I understand your point correctly, which is you're sort of saying there's not necessarily good geospatial SDOH data. So looking at the needs is one thing, but if I'm reading your comment correctly, you're also suggesting that without knowing where the resources are and what resources are in your community, it's very hard to overlay to look at where there are gaps. So do you want to elaborate on that and just confirm, did we get that comment correct? Are we interpreting what you're saying in chat correctly?
Yeah, it's really 2 points. So the first point is that there really isn't good geospatial data about SDOH needs. And I know that y'all stated that's an assumption in the model, but just wanted to point out that that's not the case on the ground. Yeah. It's important. And then in the SDOH data that is collected, very often the focus is really solely on the needs, and very little is being done on the SDOH assets and resources. And in order to coordinate the care, address those needs, you need to understand both factors and understand the gaps and opportunities between the capacity to meet those needs and the needs themselves. So just wanted to, and I didn't see the latter on the capacity to meet the needs necessarily, but that was a lot too. Trying to digest.
Yeah, no, thank you. Thank you for that comment. And what we might want to do in hearing your comment is call out a little bit more, either in assumptions or in the story. I mean, I think that part of the inherent nature of the story was to try to identify where those gaps in capacity and resources are, and are they in areas where there's a lot of diabetes. And then, one could then sort of hypothesize, okay, we need to put more resources and capacity, whether it's food pantries or whatever the case may be, to make sure that we're addressing food insecurity in those areas. So I think it's implied, but what I hear you saying is it's not clear enough and it's not called out, and we can go back and work on that. So I thank you for that comment.
Yeah, thank you so much. Yeah, and then I want to go back to Suzanne's comment, and then Julia, we can go to you. But has there been any consideration of population-based SDOH propensity indicators to support public health, might help tribes in particular? And I don't know if that was, Suzanne, was that directed for Captain Town or other folks from IHS?
Sorry, when I look at that, propensity data is out there, and it's explicitly applicable to areas where it's hard to define a population or to reach the population. So you look at it from a population matrix map, if you will, and then you do propensity indicators on for diabetes or any of the other major disease states. And then you can drill down and you can try to find out what else you can or supplement from there from classic SDOH at the individual level. But there's another layer to SDOH that I think would be interesting. And I just wondered whether that had been discussed or thought about, or because it's out there, it's being used on the commercial side. It's not cherry picking for healthcare, but it's how you do the outreach and how do you target and where do you spend your money. But it really helps find equity and access points that are needed for SDOH. Does it make sense?
Thanks, Suzanne. I think I heard you. I wonder if anybody else is doing that or looking at that on the call. I know I think for the purpose of our project, we've really tried to leverage the Gravity project use cases and the data captured at the patient encounter or at the individual encounter, and then see how that data may be repurposed. But that's a really great point. And I wonder if folks have started to do that or looked into that. And if they have examples of what they could share, that would be awesome too. I think we could all benefit from learning. But thanks for the question, Suzanne. And yeah, if folks want to put it in the chat or other questions, please feel free to do that. Julia, would you like to offer your thoughts and reflections or question?
Yeah, I think my comment was just, to really emphasize the prevention, engaging the patients with pre-diabetes, the patients who have obesity but don't have diabetes, in addressing the food access and not just, access to food or, do you have enough to eat, but what's the quality of that food? Because those things obviously link pretty effectively to ongoing increasing risk versus decreasing risk. If people are able to get access to nutritionally high quality food, that can really help them in efforts to lose weight and reduce insulin resistance.
Yeah, excellent point. I think we can, probably massage that more into the story, Amy, and folks and get feedback on how to best do that too from the CDC team. I think that's an excellent point. And then Ray, I want to go to your comment in the chat, and I hope if there's other folks representing HIEs that can talk a little bit more about this. And if we are actually, Gabby, I'm going to share my screen if that's okay, and I'll go back to this diagram. But Ray's point is that these use cases are relying heavily on the HIEs. And I don't know, Ray, if you wanted to elaborate on anything else in the chat, but do HIEs currently have the SDOH capacity needed?
Yeah, no, I mean, that's just, I haven't worked a lot with HIEs. I've worked more with distributed data networks, and HIEs are fine. It's really just a question of wanting insight on what do they currently have the capacity to collect social determinant health data from community partners, in addition to the clinical data that might be captured. And I'm just wondering, is that something that a lot of them do, or a capacity that also needs to be developed, and just an assumption here that it will be developed?
So Angie's weighed in and saying absolutely. Angie, do you want to elaborate?
Sure. Most of us are already capturing some form of SDOH data in one of two ways, or one in several ways. One is whatever is collected through the EHR or through our connections to CBOs directly, or our partnerships with a Find Help or a Unite Us or a WellSky, or through any registry data. So we're collecting data elements from a variety of different data sources and through partnerships or point-to-point connections. So definitely within our purview, we can certainly aggregate it with clinical data and create raw data sets or reporting, structured reporting around it. So, and this is actually where most HIEs are making a huge investment right now. And then I would just add to this point, we're really in my own organization, we're really transitioning to say that SDOH is part of our cross-sector data sharing to make sure that it supports all of our health equity principles and all of the health equity initiatives that most of our healthcare ecosystem is focusing on, to make sure that it is comprehensive and robust, and also inclusive of all of the different stakeholders that do have those data assets that we're looking for in the SDOH community. So making sure that we have a vendor agnostic strategy that we want to play with everybody and just be the data aggregator across all of them. We even have an interoperability pledge that we are working to get all of the CIE folks to try and sign on to, so that we can get conformity on data collection and standardization of data when we do share it and collect it. So really working very hard on this effort right now.
Thanks.
Chico, there are a number of comments.
Yeah, I was gonna say thanks, Ray, for the question, and Angie for providing your perspective. Karen, did you want to elaborate on what you said in the chat? Would be curious to hear from your perspective what you're doing.
Oh, sure. So, hi, my name is Karen Iaposi. So I work for a vendor who we are, we solely work with payers, and sometimes we work with provider entities. So in our overall platform that would manage, anything a payer would need, UMCM, DM, the whole kit and caboodle, appeals and grievances. We also have an SDOH module. So what we do is we have the ability to go right down to the geocode, right? So we can go right down to that level, map the risk factors to the members that are with the plan, that are assigned to the plan, bring those members in and layer over their clinical data that the plan has, and begin to put in next best actions, linked out to any CBRO that needs to be through, we have one CBRO right now that we're working with, that we're doing it through the FHIR application, go out, send out the referral. Once that's done, have it back into our platform as a closed loop referral. So the goal here is to be able to, the payer holds a lot of information, but yet we know that there's boots on the ground. Those entities hold a lot of information as well. And then we have this additional community data. So as much information that can be brought in to the platform to be able to then drive, what do we think, again, going back to what I think someone had brought up, you have someone who's overweight and could potentially, if we don't wrap our arms around that pretty tightly, we could end up with somebody who might end up with diabetes, and that could end up being a cost. So we look at the data of, like, are they in a food desert? Are they in an area where they don't get the healthy food? There might be Burger Kings and McDonald's all around, but really, are they close to someplace where they can get healthy food and start to drive interventions immediately that way as well? So we're trying to help our payers manage this as well. And we've just set it up that we could take information in from any data source and start to work it through, just to try to help, because this is a big, as someone once said to me, this is a big elephant, and where do you bite, right?
Yeah.
So
thanks for sharing, Karen, and Heidi as well. It sounds like in your region in Houston, the HIE is in process, and that's great. And Dr. Lewis, thank you too for sharing as well. Yeah, I guess, and I think folks on the line, I'm sorry, I'll sound like a broken record, but I think the space is really evolving, and different capacities and functionalities being built across a variety of types of organizations that might be information recipients and information sources of this. And, I just put up on the screen too, the alternate flows, because as we were developing this, if there's other organizational types that aren't, stated in here, please feel free to let us know what else we can add to make this cast a really wide net, and also try to reflect that it is an evolving landscape. And Roger too, thank you for your chat as well, and good to know about the work at Sync Health, and I think but yeah, Dr. Lewis, your comment about, as long as there's, if we can get to some standardization with this data, that's the hope, and certainly appreciate Heidi and other comments that, we're not really there. The capacity on the ground is tough. But again, we're all, I think, here trying to hopefully work towards this desired future state. And if we can leverage the collective brain power on this call to help build, relevant business case and use cases that could benefit the ecosystem, that would be, I think really amazing to then bring forward, through the Helios initiative in the future, or other standards development work that could help then build out these, more robust, thorough implementation guides.
Sheetha, Julia has had her hand up for a while, so I want to make sure we get a chance to hear from Julia.
Yep.
Yeah, I just wanted to clarify my statement in the chat. So I said not really, but the not really was the HIE often doesn't have a rich repository of diverse data that it is really routinely getting exchanged. Not that they don't have the support for SDOH data. I think they do. And I think, Sync Health is a great example of an organization who's been really working extremely hard on helping sites to figure out how to get and normalize their data. Most organizations that are in an HIE or HIE capacity have told me, like, it's kind of a nightmare to do the normalization of this data because it's not well formed or structured. A lot of organizations are sort of doing the, we built our own tool and here it is kind of approach still. I don't think that USCDI really helped that because it sort of said, do this. From the hospital system that is sort of most closely affiliated with my FQHC. Now on every single discharge summary for transition of care, I get an entire page of blank questions for SDOH. I've never once seen a single item actually filled in. It just makes the document an entire page longer. I get the idea, the intent of it, but I think that there's a number of gaps between sort of where we want to be to have real meaningful exchange and where we are now. And HIEs probably do a good job of supporting in the data warehouse level, but the data that's coming out of systems, our specific experience, because we're trying to normalize, maybe 20 different organizations SDOH data, is pretty messy to the point where a lot of it's not very useful.
Thanks, Julia. I guess we got our work cut out for us, huh, folks? Laureen, would you like to just let me see yours? What are the specific sources for SDOH data that payers are linking by zip code? Was that maybe addressed to Karen or just general to the work group?
Yes, to Karen. And I think, did Roger say that you're at Sync Health? I'm not sure what that is, but anyway, I was curious about for Roger and Karen, what are the specific data sources they are linking at the zip code level?
Sure. So I can talk about what we're doing as we get down right now. We're doing education, housing, home, housing, food, transportation. We are also doing let's see, we have education, housing, food, transportation, safety. We have like 6 or 7 different down right to the level. I can pop it into the chat for you, but we're pulling all of those pieces of data, and we're also linking households just to, as a wider scope. When we talk about this, you can have many individuals that are living in a household with different names, or grandma's taking care of the kids, or kids are split between households. So we're also trying to link those households as well. But I'll pop in the chat what we're capturing right now, and then what we drive, then we drive it into a workflow and layer it over your clinical data, and then try to, it's like taking Jello and tacking it to a wall, but try to help our plans and our clients look at a potential like ROI, because that's been the big hot discussion right now. And an ROI just is not always about the dollar. Sometimes you spend more money, but you're getting, in the long run, you'll get a better outcome for the member. But anyway, I'll pop that stuff in the chat. I'm sure you guys will be hearing from me more.
This is great answer. I did want to, do you using mostly ACS data that you're linking, or where are you getting the data on transportation, housing, education, food, and so on?
Yeah, it's some of it's the US, it's the .gov, and then we do have some vetted data that's down to even a deeper level. I would have to talk to my tech person for him to give me the full spiel on it, but I can bring it back to the group as well. But we go right down to the geo map. Yeah.
Great. Thank you so much.
You're welcome.
Great, thanks so much. And I know we only have a few minutes left and definitely want to keep folks on time. So Gabby, I will pass it to you to help close us out and talk about next steps.
Absolutely. Thank you so much to everyone for chiming in and keeping our discussion very lively. So I have the honor to just close us out and kind of recap a little bit of the homework between meetings. So if you were unable to provide feedback during today's call, you might be digesting it, or you want to, reflect a little more on the story and what we covered today for use case 2. We encourage you to please download the Word document with use case 2 components. You have the option to comment, write in specific areas. Some of you have been, providing comments throughout the work groups. It's really nice to see them. And you can email them to me. I'll be triaging and by Wednesday, June 22nd. So we have enough time to review and compose a response for inclusion into the use case 2 component. So really want to thank you for your time. We know that this is all hands on deck kind of process, and we cannot do this without all of you. All the input from today's call will also be incorporated, but any additional thoughts are extremely welcome. As Amy and the team alluded, we are continuing to ask you, if you are able to provide it's an optional homework assignment, submit persona candidates. We review, as you saw earlier today, the 4 additional personas that were submitted. There is a spreadsheet that you can download. You can rename it with your name so we know who's submitting items, and you will email that to me as well, and we are compiling them and making them visible on our Confluence page. So all of that information is from and to the work group. And for some of you who might be, depending on where you are within the ecosystem, might already know that the Centers for Medicare and Medicaid Services, CMS, is partnering with HL7 on a Fire Connect-a-thon that will take place in July. You can register for this free event through June 30th. They have a few roles. If you are a vendor that's able to bring code, the Gravity Project is seeking for social determinants of health and health equity data integrators, depending on where you are placed, whether it's as a vendor, payer, HIE, so it can help us test and validate the FHIR implementation guide as it relates to social determinants of health clinical care. If you have a technology solution, again, we really want to connect with you. You can sign up. I'll make sure, and Savannah, if you don't mind putting the link in the chat, don't have it handy right now, but we are very much looking forward to engaging on testing through this Connect-a-thon with all of you. And I know we are right on the top of the hour. You have our contact information. If you have any questions, if you'd like to share, any additional thoughts, we welcome that. Again, my name is Gabriela Gonzalez, colleague Savannah Muller behind the scenes supporting our call, and then Kyla Davis is the point of contact at the CDC, National Center for Chronic Disease Prevention and Health Promotion. And I think right at the top of the hour, we want to thank you again for your participation in this national consensus building process. Today's recording will be posted on our Confluence site, and you'll receive a follow-up email with the materials that were discussed today. Thank you all, and hope you have a great rest of your day.